Thank you so much, everybody, for joining us for this next session. And thank you so much, Dr. Cortez, for joining us today. So my name is Alexia, and I am the co-president and co-founder of the National Pre-Health Conference. And it is my pleasure to introduce Dr. Fernando Cortez. Dr. Cortez is a board-certified emergency medicine physician from the University of Arizona College of Medicine, and he's currently the emergency department site lead at Florence Hospital. He came to Arizona in 1987 and graduated from ASU in 2001 with a bachelor's degree in microbiology and a minor in history. He's also the founding member of FACES, along with the MHEP and ASU AMSA chapter. Furthermore, he's happily married with 3 kids and goes on camping and hiking trips during his spare time. And he will never pass up a midnight taco. Today, he will share with us his experiences of emergency medicine in a rural setting. Let's give it up for Dr. Cortez. Thank you, Dr. Cortez.
Thank you so much, Alexia. Can you guys hear me out there?
Yes, we can.
Okay, great. Let's do... We'll go ahead and I'll just do the presentation this way, or I'll go ahead and start the video. Not a big deal. Okay.
You can give the presentation with or without your video, whatever you
All right, cool. Let's see, awesome. So in emergency medicine in rural settings, so thanks, Alexia, for inviting me out to this conference. It's always exciting to be able to talk to pre-health students about emergency medicine and why I went into this and just medicine in general. There's been a lot of interesting changes the last couple of years with COVID, as with everything else. But it's always a fun opportunity to be able to at least discuss what our job outlook is and what we have going on here in the coming years. Now, just briefly, I'm going to talk about just emergency medicine in general as a specialty. I don't know in regards to the audience as far as what your exposure has been to emergency medicine, if you know about it as a specialty. Usually it's not, well, since it's not one of the standard primary care or general specialties like internal medicine, pediatrics, OB, family medicine, not many people really think about EM during residency. There's always a TV shows that talk about it quite a bit. And you see all the exciting things on TV about it. It's not all that exciting all the time, but it can be sometimes. In any case, so just as far as any conflicts, there's nothing to disclose. I have no financial disclosures with any of the organizations I'm going to be discussing today. Just brief, little bit of a history of emergency medicine. So EM essentially was founded by necessity by a couple different groups, one in Virginia and the other one in Michigan. In Alexandria, Virginia was essentially just a series of full-time docs that said, hey, we're going to do this full-time. And they started some of the first emergency departments. In Pontiac, Michigan, it was just a series of full-time docs that said, well, let's just do this part-time. Little by little, that just kind of floundered and then subsequently developed further. And the American College of Emergency Physicians was founded in 1968 as a response to the need for patients receiving unscheduled and emergency care. There was a big demographic shift in the 60s, and as more and more people were finding themselves without access to physicians, it necessitated the hospitals being open 24/7 and to have a physician staffing the ER. The first training programs were established in the 70s with the first residents graduating at that time. And emergency medicine was officially recognized as a specialty by the American Board of Medical Specialties in 1979, with the first certification exams coming out being done in 1980. Now, I apologize, the next couple of slides are a little bit verbose, but they pretty much sum up what I do as an emergency medicine physician every day, and was what we do essentially as a specialty. So I'm just going to go briefly and just highlight a couple of points. And once again, I apologize if they're a little bit verbose, but they're straight from the American College of Emergency Physicians. So EM is a medical specialty designated to diagnosis and treatment of unforeseen illness or injury, encompasses unique body of knowledge, which includes the evaluation, diagnosis, treatment, and importantly, coordination of care among multiple clinicians or community resources to disposition any patient required expeditious care. So that coordination and the disposition is key. Usually you'll see us as the point of the spear in taking care of patients, especially the acutely ill patient or the patient that comes into the multiple trauma. Brief example, I had a young woman that was shot through the left side of the head that was pregnant. And essentially I was there leading the team. This is in a rural setting, by the way, in a rural setting, coordinating the different specialties, neonatology, OB, and then myself, as well as the air crew team, in stabilizing this patient and then sending her over to a trauma center. Her and the child eventually did fine, but it's that training that you receive during residency, and then you continue to develop that during your practice. We're not defined by location. We practice in a variety of settings: urgent care, standalone, small hospitals, large hospitals, disaster sites, or even telehealth, especially as during COVID, telehealth has become more popular. So EM encompasses the planning, the oversight, the medical direction for the emergency medical response as well. And we provide administrative and leadership services to not only urban centers, but especially rural centers. And that leads into what I'm going to be talking about today as far as practicing emergency medicine in a rural setting. We provide that leadership to be able to coordinate care to the patients that live in these communities. And finally, for better or worse, I believe this very strongly, that we are the safety net, or the foundation of the safety net of the healthcare system. Some clinicians maybe derive that a little bit, some don't believe in it. But I think, as my role as an emergency medicine physician, I am the safety net of that community, and I'm able to provide that care that they need in an expeditious manner. In continuing, before I talk a little bit about emergency medicine training, if there's any questions or whatnot, we can have some Q&A at the end. We're a little bit, maybe a third of the way, I believe, through the slides, if you will. And, I'm leaving plenty of space to talk about emergency medicine in general. I'm more than happy to chat not only online, but offline with anybody that has any questions. So, excuse me, the training. So you start obviously medical school, you got 4 years, and then residency can be either 3 or 4 years. That comes from where emergency medicine, its origins, where it was a 1 year of general medical training and then 2 years or subsequent 2 years of emergency medicine. Those programs eventually became a 4-year program, and then the newer programs became 3-year programs. So it's a 3 or a 4-year residency. I think they're both beneficial. It depends on the type of person that you are and the type of training that you're looking for. There's academic training programs, community-based. I trained at an academic program at Penn State, but there's many outstanding community programs out there, just like, there's many outstanding academic programs. It all depends on the type of program that you want to go into. Urban versus rural setting. Quite honestly, there's different places where you can set up and practice emergency medicine. I myself tend to be more of a fan of a training program that has enough repetitions and enough exposure to the breadth and scope of emergency medicine. And that's something that we're going to talk about in a little bit. Education within a residency program involves trauma, general medicine, and critical care, both adult and pediatric. There are fellowships available after residency that can last anywhere between 2 and 3 years. They involve toxicology, pediatrics, ultrasound, undersea hyperbaric medicine, education, etc. Wilderness medicine is one that I enjoy, but there's definite fellowship opportunities as well. There are some controversies regarding residency program expansion. So within the last couple of years, we're going to talk about this a little bit more in regards to the training program expansion process, how more and more residents are graduating and causing almost like a surplus of emergency medicine physicians. And we'll delve into that a little bit further. There's also some controversies regarding advanced practice provider use in the ED. such as nurse practitioners and physician assistants. I see them as part of the healthcare team, others don't. I know in this conference already there's been some discussion about this, so to speak, but I'll kind of give a little bit of an emergency medicine viewpoint on this. Once you graduate residency, there's a board certification process. It's a written and an oral board exam. You take practice exams during residency in preparation for this test. It's just like any other exam that you take during residency. During medical school, that's several hundred questions, and you get used to taking exams. I mean, it's not a big deal. It's something that you should be well prepared for by going through an EM residency. And then there's an oral board examination process afterwards where you sit in front of academic emergency physicians and you answer questions. It's not an inquisition, but it's more of just a question and answer process so that they know that you essentially do know what you're talking about, and then you can essentially be board certified. There's a maintenance certification process that occurs every 10 years by taking another official exam. It's a written exam, by written, I mean computer-based. And that exam is actually going away. We're going to do a certification called My EM Cert that starts every 5 years. And every 5 years, essentially what we're supposed to be doing is an exam a year. It's open book. It's breadth and scope of emergency medicine, just to keep us essentially educated in our specialty with the most recent advancements. LSA exams are lifetime learning self-assessment exams that we do based on current literature. They take the College of Emergency Physicians and American Board of Emergency Medicine chooses about 10 to 15 articles that we read, and we answer some basic questions to ensure that, yes, we did read and we understand those articles. It's actually not bad and quote unquote fun. They're actually, pretty informative, and they help you take care of your patients. So I'm a fan of them. Now, the job outlook. I'm going to spend a couple minutes on this slide, just in full disclosure, and so that we all know essentially what we're going into as we're going into medical school, if we're planning on choosing emergency medicine as a career option. Now, there's been a series of job analyses over the past decade that have demonstrated a possible scarcity of emergency medicine physicians. And that led to a logarithmic increase in training programs. They've been popping up all over the place around the country and graduating numerous residents every year. In 2017, 2018, the American College of Emergency Physicians looked at it and said, well, we're getting a little full. We need to take a look at this and see if we need to maybe curtail some of these graduates graduating or curtail the growth programs, because at least 80% found, although 80% found had no problems finding jobs, in subsequent years become more difficult. Obviously, COVID screwed everything up. ED visits dropped 40% nationwide, and there was a contraction of services among hospital facilities. Hospitals started shutting down, and several EM doctors found themselves without work. I know my hours actually increased, and they actually expanded from 8-hour shift to 12-hour shift because of decrease in volume. There was a workforce study in 2021 that addressed this, and they said, well, holy crap, we screwed up in the numbers, our assessments. We're going to be full by 2030. But they're still looking at those numbers and seeing what's going on as far as, okay, are we going to continue expanding? Are we going to contract? Are we going to curtail the training? Because granted, with the increase in training programs, some of these programs are not the best in the world and might be graduating some residents that are not essentially prepared. It is a controversy, and I know it's something that we're continually looking at within a specialty, but more information coming from that. In 2020, and this is going to lead into what we're going to talk about today in rural emergency medicine, there's a national study of the EM workforce that was done by emergency medicine, by the ASAP, in looking at, okay, what's really going on with our numbers? And I'm going to go over that study in detail here shortly. Essentially said that urban centers are well-staffed, rural hospitals are underserved, and it fits what I believe is an anecdotal student and resident model that we'll talk about further in regard into graduating resident options. Now, briefly about APPs. nurse practitioners and PAs are an important part of the healthcare team. There is a lot of discussion back and forth as to what the role is of APPs within emergency medicine. I think that supervised nurse practitioners and PAs are an integral part in taking care of patients in the ED. It allows us to take care of sicker patients. It allows us to take care of more patients in an expeditious manner. Now, I'm not going to address the controversies back and forth between physicians, nurse practitioner organizations, and PA organizations, but suffice it to say, those are things that we can discuss offline. But bottom line, I think that we can all essentially work together and without the feeling of, well, someone took my job type of deal. And I mean, I don't think that's the case. I think that healthcare entities and institution will make the best decision they want from an economic standpoint. And, unfortunately, we may be cut out from those, we are being cut out from those decisions. Telemedicine has made it easier to support APPs. But at the same time, we know our worth, and hospitals do as well. So rather than infighting and rather than the discussions, we should just have more of a collaborative discussion as to how can we better take care of our communities. So with that being said, just before I segue into rural emergency medicine, I just want to give you guys a heads up why I'm doing it. So as I said before, and thanks, Alexia, I graduated from ASU, went to U of A, graduated from Penn State in emergency medicine. I've been practicing for a decade in both rural and urban settings, large hospitals, rural facilities, standalone EDs, and I'm a site lead in rural ED here in Arizona. And what got me into it was when I was an undergrad at ASU, in founding FACES and AMSA, we started a migrant health, what's called MHEP, the Migrant Health and Education Program in 2001. Basically, a couple of us looked at different places around the state saying, hey, why don't we go do something? Very naive, if you will. I mean, taking a little medical bag and going out there. One of the people that founded it with us was an ex-Special Forces medic. And his experiences actually kind of built that fire under us in going out to different rural settings to provide Head Start physicals. And we obtained a grant from Susan G. Komen to do mobile mammography in some of these locations. Interestingly enough, as I started practicing emergency medicine a decade ago, I actually went and practiced in some of these sites again as a physician. It was very rewarding. But yeah, that's what kind of led some of the interest in going out to more underserved and rural communities. Now, what is the definition of rural? Census Bureau, White House Office of Management and Budget, Centers for Medicare and Medicaid, all have different definitions on what is rural based on population, geography, demographics, urban versus suburban populations. Nobody really has anything official in regards to what the definition is. For our purposes today, we're going to talk about urban, which is a city, and not urban, which is a small town in the middle of nowhere. That's kind of the best way that I can describe this. Now, the American College of Emergency Physicians has a rural emergency medicine section that you guys can take a look at if you're interested in rural emergency medicine. But their definition of what rural EM is urgent or emergent medicine practiced in geographic areas with low population densities and resource constraints. Basically saying in the middle of nowhere without much stuff, including ready access to more specialized care facilities. Rural EDs, we provide critical services for the communities and especially facilitating entry into the healthcare system, stabilization and transfer/transport to a tertiary care facility. A tertiary care facility is a facility, it's a major hospital, a major medical center. For example, Banner University in Phoenix, UMC in Tucson, Banner Desert in Mesa, UPMC in Pittsburgh. Sorry, I'm kind of a little more Pennsylvania centered, but you get the drift. Tertiary care facility is a hospital that has every specialty available with numerous avenues of support. And I'm sorry, that comes from the ASAP Rural EM section. So I'm going to delve into this because it really deals with the crux of why go into emergency medicine in a rural setting. The study of the EM workforce came out in 2020. There were approximately 50,000 active EM physicians in 2020. Median age was 50 years. I'm not there yet. I don't care what Sarah says. Median age was 50 years, 28% were women. And the overall density of emergency physicians per 100,000 population was 14.9. Most of the doctors, and this is what I want you guys to key on, were in urban areas. Only 6% were in large rural and 2% in smaller rural areas. So essentially, this tells you that's a huge disparity, and I'll explain why. So the national study of the EM workforce continued to say that in urban settings, there were younger physicians than those in large rural areas, and most likely to be women. Most physicians in rural areas completed the medical training more than 20 years ago. So it's an aging population of clinicians that have been practicing for quite a while. And even though the total number of physicians increased between 2008 and 2020 by almost 10,000, the density actually decreased quite a bit in rural areas compared to urban populations or urban centers. Sorry. So I am going to have these slides available through the conference. So if there's something, if I'm going a little bit too fast, please let me know. I'm actually clicking on the comments and on the chat and a little bit of the QA as we're going. So moving forward, rural emergency departments. Now, 42% of EDs in the US are classified in rural counties, all based on geographic isolation and acuity. Sorry, geographic isolation and acuity are a hallmark of rural EDs. You tend not to see the critically ill patient until they come in. And I'm sorry, it sounds kind of weird saying that, but for the most part, it's lower acuity, the sprained ankles, the belly pains, occasional chest pain, some orthopedic things. But then when you see something crazy come in, as I occasionally do, you really have to think on your feet. You are essentially all alone and nobody is coming. So that's why when you graduate from an EM specialty or you graduate from an emergency medicine residency and you start working in these places by yourself, this is essentially you. It's that horrifying moment that you're the only attending, you're the only doctor in the hospital, and you have somebody critically ill. So you have to go back on your training, trust your staff, trust the people that you work with to stabilize that patient, take care of them, and to get them to a place that they'll get that definitive care. But you're it. You're essentially the tip of the spear, not to borrow the SF community, but you really are. That's my favorite meme. One of my favorite memes of being an attending, by the way. So there's no trauma, no stroke, no sepsis team. You really got to think on your feet and solve some of these complex issues on your own. Telemedicine is helpful. I have often relied on critical care specialty support via telemedicine with some of these critical patients, especially because there's a prolonged transport time. You're talking about hours to get some of these folks from X location where you are to that tertiary care center. So you have to continue the care. Not only do you practice emergency medicine to stabilize the patient, but you also are practicing critical care on that patient. You are the critical care doctor. You're the intensivist. You're the pediatric critical care doctor. You're the surgeon. Obviously, you're not doing surgery in the ED, but you're continuing to stabilize that patient to get him out. Excuse me. Now, in rural departments, there's a camaraderie that develops among medical staff. And you do see a whole diverse amount of pathology. Anything from the heart attack in one room to the other room, somebody who had a crush injury, just somebody who went skydiving and sustained an ankle fracture, to somebody who got stung by a scorpion or got stepped on by a cow or weird infectious disease things. And so you're constantly thinking on your toes, which really adds diversity, and why I chose emergency medicine as a specialty compared to others where you're not really specialized in one particular aspect of medicine. You see everything. And then another part that's dear and near to my heart is that you really get involved with your community. There's a lot of excellent patient care that you can provide to these folks, and you get to know them. You really get to know their families. You get to know them as individuals, as human beings. And that's one of the reasons why I've loved working in rural settings. I see these folks over several years, and I get to know them and their issues, a lot like a family practice medicine doctor does. But at the same time, you get to take care of them in their hour of greatest need. So let's talk about the negative sides. And a big portion of what I'd like to talk about and maybe criticize a little bit. I have some time here, and I want to focus on this slide in particular. So there are perceptions to emergency medicine physicians out in the community. I'm sorry, in rural settings. There's a competence factor. When you're talking to an urban physician or a tertiary care center, they perceive that you're not as smart. Why are you working out there? Are you a less competent doctor? Do you have malpractice on board? Have you done something wrong to work there? And that's one of my favorite things, to dispel the rumors. I love taking care of a critical patient, sending them out and receiving the phone call a couple hours later by a physician or a trauma surgeon or a specialist at the tertiary care, the main hospital setting, going, oh, wow, they're really sick. Wow, great job, thank you. And obviously I'm not trying to, pound on my chest or anything like that, but I'm just saying that there is that perception, and that's my job as a rural emergency medicine physician, to dispel those rumors, saying, hey, I'm a board certified doctor, I am competent, and I'm here to take care of that patient and to send it to you because they're sick and they need that care. Otherwise, I just keep them with me. I'm not calling you at 2 a.m. because I want to talk about the weather. I'm calling you at 2 a.m. because I got someone sick that needs to come your way. Now, and that's kind of leads into a little bit more, that we're a little bit devalued, if you will. Don't you have the hepatologist? Don't you have that pediatric liver specialist or that X specialist? No, we don't. We are sending them to you to get that definitive care. So there's a little bit of a myopic view from urban centers. And you do feel a little bit professionally isolated at times. That's why I'm constantly reading and studying and going through the professional organizations, keeping my CME up, and to make sure that I have that important bit of knowledge when I'm taking care of my patients. Now, this is the part related to you guys, especially to you guys, the ones that are attending this conference. And once again, thanks for listening a little bit of my diatribe in emergency medicine. But part of the reason that rural centers aren't really well staffed is because, as a medical student, and a resident, you have mortgaged your 20s. You have spent all this time training and going through this difficult process, and you want to graduate and you want to go somewhere fun. You want to be in a place that has culture, a place that is not where you did your residency. You want to be somewhere exciting. You want to be somewhere fun. You want to be in New York. You want to be in Chicago, LA, Pacific Northwest, Miami, somewhere that's a big urban center. You don't really want to go to an urban setting and just, for lack of tense purposes, just not have fun, if we will. And so that's one of the issues that you deal with. And one of the things to think about as you're going through residency. A lifestyle. Maybe you want to be in a more exciting place. Or maybe, I just want to work, do my shift, see my people, and just get out. I just want to go home. Forget this. So those are all things to think about. And those are all valid points. That's what I call basically a little bit of an anecdotal student resident model, where, people, and I'm going to be quite honest and frank, people say, hey, I want to go to med school. I want to be a rural doctor. I want to do this and that. I want to be underserved. I'm serving underserved areas, and all this verbiage, if you will, and all this rhetoric. But at the end of the day, when you're done with your training, you might lose a little bit of your sight. You might lose some of that passion. And that's where you have to keep that going as a resident. And you have to really look into yourself and say, okay, do I really want to practice in that setting? Or do I just, and And by all means, I'm not saying selling out. Please don't get me wrong. Please don't get me wrong. But, or, do you want to, go to a city, go to a location, a suburban center where you really, you practice the medicine that you want to practice at the end of the day. You practice in a place where you feel comfortable, where you feel that you can get your best growth as a clinician, and you can take care of your family. Those are things that I looked for. And although I live more in the outskirts of the Phoenix metropolitan area, I enjoy the drive to some of these rural settings. And, I've enjoyed my practice for the last decade. I love what I do. And it's something where it is truly a lifestyle option. I had an option after residency to go to a very rural setting. And my wife said, you know what? I'm not really wanting to live out there. And I said, okay, fair enough. I'll still be able to practice my medicine, but I'll have to, kind of live in a place where my family wants to be. And so those are things that you have to think about as you go through medical school and residency. You're going to experience the most growth you've ever had in your life these next few years as you go into med school and then onwards and upwards. You have to, pardon the adage, learn and know of thyself. Know what you can handle, know of your capabilities, and then at times you have to exceed them. So to that end, just want to briefly go over a couple last things before we go into some Q&A. There's some rural emergency medicine resources out there that you can look at from ASAP. Ed Leap is an ER doctor, has been practicing for many years, and he has a great article on why he likes practicing rural emergency medicine. There's a journal that was published for a couple of years on rural EM resources that I encourage you to take a look at. But these are some of the official EM resources as well, ASAP, SAME, AAEM, and EMRA. Thanks so much for your time, guys. The first picture on the lower left is the lights in the background of the Phoenix area. That's a sunrise at about 5 a.m. when I left, as I was leaving one of my rural sites a few years ago. And I love that drive. I love being out there and the middle of nowhere. I love camping. I love being out with my family out in the woods. The other picture is my wife and kids with the San Francisco peaks in the background. I love being outdoors. I love the capability of going to the urban center. My wife and I do enjoy going to the symphony. We do enjoy a lot of the trappings of the city that the city has to offer. But at the same time, we do, and I do enjoy practicing in that type of rural setting. So let me go a little bit more into the chat. And then I'll work with the host and panelists on putting a link to the presentation, but a couple of questions that have come up. So, how do you build leadership and problem-solving abilities over time? So that is a great, great question. That's something that you develop as you get a little bit older. If I can ask the hosts, if they can kind of re-enable the video, more than happy to.
Yes, first, hello, Dr. Cortez.
Yeah.
And everybody in the audience. My name is Rani and I'm the host director, and I'll actually be doing the Q&A with you today.
Oh, you will? Okay.
Yes.
So one thing, as you do the Q&A, there's just a couple questions that came up on the Q&A section. If that's okay, if I can just address those for a sec.
Yes. And
right, cool.
If you could stop sharing your slideshow, that would be great.
Cool.
Awesome.
Sorry with the, all right, cool.
All right.
So with the,
for the first question, it says, how did you build your leadership and problem-solving abilities over time?
Okay, so how do I develop those leadership and problem-solving abilities? Those are things that, as I was talking about earlier, you develop on your own. You are going to look at different models of people that you work around. And as you continue the learning process, as you continue your education, you will develop those leadership skills, if you will. And those are things that you develop over time. It's not one thing that you develop within 24 hours or a couple of weeks or a couple of months. It's something that you develop over the course of years and whatnot of practice and experience. So hold on, there's another question here. So I'm sorry, go ahead, Raniel.
Yes. So for the next question, they're asking, do you think there's a select personality type for emergency medicine? How did you know it was for you?
So how did I know that EM was for me? So it's interesting. When I did a mock interview for the U of A, when I was an undergrad in the early 2000s, the person that did a mock interview for me was an EM physician practicing over in county. And he said, hey, I'll do the mock interview. Hey, no problem meeting you. I'm going to meet you at Starbucks over by ASU at 5 p.m. after I pick up my kids. And I said, that's a specialty for me. So the ability to have, that openness, that ability to have the freedom of schedule, not tied to a pager. I was tied to a pager when I was an undergrad working in organ and tissue transplant, where I would be on call from like a Friday to a Monday, and I would have to leave class. I would be working all weekend. Luckily, we didn't have any kids at the time. We had just gotten married. And it was, it was challenging. It was one of those things like, man, I don't really want a pager again. I had one during residency, and then afterwards, I was happy to drop it off. Now, I still have a phone as a director. I'm constantly, answering texts and things like that. But one of the things that I really enjoy about my specialty was, that ability to be a little bit free, a little bit more free within the House of Medicine. Now, I'm going to dovetail into one of the other questions that was asked. The care of the patient in the acute setting, being able to practice critical care not only in adults and kids, and being able to provide that service to not only the community, but my neighbors, and also in practicing wilderness medicine, are some of the biggest things that led me into emergency medicine. The ability to know what's going on in that patient, or be able to figure out or have a list of things that could be going on with that patient at that point in time, is what led me into EM as a specialty. Also, the fact that, I'm being quite honest with the panelists and everybody attending. I like the fact that I can just go, I can work, I can provide the best care that I can for a period of time, and then I can go home. And then I repeat again the next couple of days. So I know you're going to be asking, kind of going along with another question. So some of the pros and cons and skills you need to work in emergency medicine: definitely time management, organizational skills, the ability to think on your feet, and the ability to quickly think about what is going on with that person, what's going to kill them within the next 15, 20 minutes. Now, it can seem overwhelming, a little daunting at first, but that's what you do training for. That's why you go into residency. Without being too controversial, that is why you go through a residency process. 3 to 4 years to develop those critical care skills. 3 to 4 years to develop that know-how, that differential diagnosis development capability. To be able to look at that patient and say, okay, you don't have this, but you probably have this. We're going to go down that pathway and make sure you're not going to die. Make sure that what your complaint is not one of those critical complaints that could kill you. So that's where some of the skill sets that you develop during residency. You can start developing them during medical school, but you are going to be continuing to develop them during residency as well. And hopefully by the time you graduate, you'll have that skill set behind you. Now, you're going to continue developing those skills as you go on in your practice, but those are some of the skill sets that you develop during a residency process.
Awesome. Thank you, Dr. Cortez.
No problem.
And then for the next question, we have, apart from being in a less populated area, what are the differences between working in emergency medicine in rural versus urban areas?
Oh, and as I mentioned a little bit in the presentation, in the rural setting, you have less resources, less specialty support, less backup. In urban areas or major urban hospitals, you have full specialty backup. You're not that little cat on your own, looking for the attending. You have the trauma team next to you, you have the other specialty support next to you, or available to you to come down to the emergency department and see that patient, that you can just hand the patient off to them. And that's one of the biggest differences between rural and urban areas. Rural areas, you really have to think on your feet. You are on your own. And you have to develop those skills to take care of that patient quickly and transition them or transfer them expeditiously to the tertiary care center.
Thank you. And then I'm also wondering, Dr. Cortez, how many patients do you typically see in a day?
Oh, it depends. It really depends. In a rural setting, I was talking about 12 hours earlier.
Mm-hmm.
That was an interesting exception in an urban center where the group that staffed it, the company that staffed it, really wanted to get the most out of you. It wasn't very conducive to a good lifestyle, by the way. But usually I see anywhere in a rural hospital, limited resource setting, I might see 1, maybe 2 patients per hour in a 12-hour shift. When it gets busy, like it's been busy the last couple of days in our facility, I was seeing upwards of, closer to, more than 2 patients per hour. But it's a little bit of a misnomer because I was really seeing 5 patients per hour the last couple of hours of my shift. The first half of the shift was relatively empty, and that's typical for a rural setting where during certain parts of the day, you're not going to see very many patients, and then everybody comes in during a certain time. It happens in urban centers as well, where everything just kind of ramps up at a certain time, a certain hour, and then you have the backup for it. In a rural setting, you don't. So you're stuck there. And that's where you depend a lot of the nurses and the techs to kind of help get these patients back, see the sickest patients first, and then triage to the lower acuity patients, like the ankle sprains or an earache, things like that, kind of like a little bit lower down the list.
Great. And I think this is a good transition to the next question,
Mm-hmm.
which is, do you encounter frustration from the limited access to resources? How do you tackle this? Also, how do you make patients feel at ease or in good hands?
So that is I experience that every single day. I mean, that's what I do every single day in a rural setting where, I do get frustrated with essentially apathy that you get from the large institutions at tertiary care centers, where you've invested so much time into your patient. You put them at ease and you let them know, hey, you have a pretty serious condition and we need to send you to a major center to get taken care of, or to get the care that you need from those specialty services. And so I routinely come across, whether it's a admitting physician at these centers, like a hospital physician or a specialty physician that says, well, why are you sending them to me? Why this? Why that? Essentially, it's just it's just another person I got to take care of from this far-flung place out in the middle of nowhere. Why me? There's a lot of stabbing yourself in the chest in medicine from doctors, and it's been there for eons, and it's quite frankly that has to stop. But regardless, it's something where I just kind of take a step back, and to answer Leslie's question, I take a deep breath and I don't yell on the phone or say, blah, 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 you, or, you're a bad doctor or XYZ. I just take care of my patient the best I can, and reassure them that they're going to get the care that they need. And then that provides me with the emotional support, if you will, to deal with some of these issues. I've had specialists berate me on the phone saying, you're stupid. Why are you sending this? I don't need to see this. Or, why are you sending this patient to me? And, why aren't you sending him to this other place? So I deal with a lot of those frustrations every day. More often than not, it's interesting. I've actually, in a small number of cases, I've had those specialists actually call me back and apologize. We all have a bad day. We sometimes blow up on the phone.
Thank you.
Mm-hmm.
And for the next question by Joshua, since you have more responsibility over a patient's life in the rural setting, does that make death harder to deal with?
Well, it's a great question. I've been practicing long enough where it doesn't really get me as much as it used to when I started practice. Pediatric codes, when a child dies under a tragic circumstance, that's difficult. And so you almost have to develop kind of like this moral core where, interesting, I'm actually dealing with this right now in my rural site where you do have that child that's dead or that person that's dead coming in. And so in that instance, when that person comes in and there's a possibility to resuscitate them or bring them back, you have to work closely as a healthcare team to really get the medicine in front of you, get that patient kind of separated a little bit, the patient from what's going on, take care of them in an expeditious manner, see if there's a way to reverse what's going on. With the understanding that, if they're going to come in dead, they're probably already dead and there's not much you can do for them. But you have to be a competent clinician with all your skills ready at your disposal to take care of them. And then when you're done, they're dead. It's okay to cry. It's okay to come together as a team and say, hey, we did our best. And we can debrief, we can decompress. I did that 2 weeks ago with our team where we just sat in a room and we just cried for a half hour. We had to. You have to. I pronounced a dad from, he had 2 boys with him, and it was a pretty tragic circumstance. And, afterwards, it was one of those where, I told those boys, they were my boys' age, hey, your dad's dead. And, it was difficult. It was very, very difficult, but it's okay to cry. It's okay to take those emotions and just let them, come out at a later moment. But at that point in time, you got to take care of that patient. You can't let that emotion block your way saying, oh crap, there's a dead person, there's a dead kid. And you got to take care of them. And these skills you develop as you go on, as you develop your practice during residency, and then you go on your own practice. So it's okay to have emotions.
Thank you for sharing that, Dr. Cortez.
Yeah,
I think that's such an important point, actually. And even especially as undergraduates, we may also be stressed, but also that you have to acknowledge it as well. And it just shows that, we're human, and just realizing you're not alone. You're not alone in this situation, especially when you're doing it with your team. I think that's such a great point. So thank you for sharing that with us.
Yeah, no problem.
So the next question is, Dr. Cortez, what was your personal motivation to pursue emergency medicine in rural areas for particular?
So, it started working as an undergrad with Migrant Health, excuse me, and also working with organ and tissue recovery. We used to fly out to rural hospitals and rural settings. And I find myself a little bit more at ease in a rural hospital. I don't want to say that, big fish in a small pond or whatever like that, but more of, I think there's a little bit more collegiality with the medical staff at rural settings. There's a little bit more of an interpersonal relationship with the patients that you have at a rural hospital. And so those are some of the big motivations that keep me working there. You get to know some of these folks over the course of several years, and there's a little bit more intimacy among the staff rather than a gigantic institution.
All right. And then for our next question is, what habits or mindsets have empowered you in your medical journey?
Do
you have like a motto in life?
A what?
Like a motto in life?
So we have 2 minutes. Okay, good. We have more than 2 minutes, but So, a long time ago was a dark and stormy night. And I had an elderly patient come in, and he was sick, had a heart rhythm disturbance that was threatening his life. And I was the lowly intern. I just graduated medical school. And so I was like this. I was like the picture of that cat. And I was looking around for the attending, and I was just an intern. I was a resident. I wasn't the attending or anything like that. And so I called the senior person who was my backup. Excuse me. And he said, I don't care. You do it. Like, well, I was going to do this, this, and this. I don't care. Click, hangs up the phone. So I give the patient medication. He does okay, but he's still a little bit sick, needs more medicine, needs to get that heart rate under control. I call this doctor again. Hey, can you help me out? No. Click. So the family could see the sweat beating on my forehead, the anxiety. I'm like, oh man, I'm going to kill this guy. So I gave another medication. It starts working a little bit, but not yet. The patient's blood pressure starts dropping a little bit. So I give him some fluids and I call this person in bed, and he just on the phone just yells at me. Don't call me again for this issue. You should know what to do. Click. So I'm like, all right, I guess I'm on my own. And so over the next couple of hours, I was working with some of the nursing staff, and I, gave a couple of the medications. Heart rate stabilized a little bit more. The patient did fine. He survived. He did great. Family was happy and everything else. And so the next day, the chief of the service, eventually this doctor got fired for other reason. The chief of the service came up to me and he said, hey, what happened last night? I heard you had some problems. The nurses told me. I go, well, I had this, and this. I called XYZ. He blah, blah, blah. And so I told him the substance of what happened. And he goes, next time, do this. But before that, did you take care of your patient? Well, yeah. Did you take care of your patient, Dr. Cortez? Yeah. So you did your job. So that's my motto. That's my mantra is take care of your patient. And I've had that with me for, 14 years now since I started residency. That's my mantra, and I live by it every single time I go to the ED. Did you take care of your patient?
Thank you so much, Dr. Cortez.
No problem.
And thank you to everyone who listened to his presentation today. So we'll be wrapping up this session with the transitioning to our lunch break. But before that, for all the attendees, we do have a quick poll. And once again, we want to thank you, Dr. Cortez, for your time and all your insights.
Yeah, no problem. Anytime.